Okay, Rachel, handing it over to you.
Welcome everybody to our TCDI webinar. My name is Rachel Kitonyo Divotsu. We'll just give 1 or 2 minutes for people to join, and then we shall start. Okay. So my name is Rachel Kitonyo Divotsu. I work with Development Gateway as a Senior Tobacco Control Advisor. And this is our second webinar where we are featuring research from the TCDI countries. TCDI is a project funded by the Gates Foundation, currently active in 6 countries, being Kenya, Ethiopia, South Africa, Democratic Republic of Congo, Nigeria, and DRC. And we have been running the project for the last 5 years. And so as part of our project, we have undertaken some data collection activities, and our webinar series is intended to disseminate this data and also bring in people from countries that have done similar research. So this is our second webinar, and the focus of today's webinar is the enforcement of smoke-free laws in hospitality venues. And so today we are going to have 3 presentations, 2 of them from Ethiopia and 1 from Nigeria, all talking about smoke-free legislation enforcement. Each speaker is going to have 10 minutes to make their presentation, and then we are going to have 2 minutes to be able to ask questions. For you to ask your question, I ask that you type it into the chat. At the bottom of your screen, you should see the chat function. Please type your message into the chat, and during the question session, I will be able to read it out and you can get an answer. If the 2 minutes for questions after the presentation runs out, then we'll also have another 15 minutes at the end of the session, again to answer any unanswered questions. Without any further ado, I would like to welcome our first speaker, Mr. Kirubel Teklu. Kirubel works as a senior researcher at the Ethiopian Public Health Institute, and he will be speaking to us about the findings on smoke-free from the Global Adult Tobacco Survey, Ethiopia 2024. Welcome, Kirubel.
Thank you, Rachel. Okay, shall I continue?
Go ahead, Kirubel.
Okay, thank you. Thank you very much, Rachel, for your kind introduction. Good morning, good afternoon, everyone. I am Kirubel from Ethiopia. As the moderator has already introduced me, I will go into the presentation. I'm very pleased to be a part of this important webinar and to have the opportunity to share our findings with you. The Global Adult Tobacco Survey has now been conducted for the second time in Ethiopia. The first was in 2016, and the second round was in 2024. So in this presentation, I will share the key findings from GATS 2024, comparing the results with the first round, with a particular focus on second-hand smoke exposure. Before talking about GATS and presenting its key findings, I would just like to highlight the tobacco burden and Ethiopia's response. Globally, tobacco remains a leading cause of preventable deaths, with over 1.3 billion people use tobacco in different forms in smoking, smokeless and heated tobacco products, and more than 8 million deaths annually, including 1.3 million from second-hand smoke exposure. So it needs great attention. In Ethiopia, GATS 2016, the first round showed 5% of adults, it's about 3.4 million people used tobacco which actually declined to 4.6% in the second round of Ethiopia GATS result. And also according to the Global Burden of Disease report, tobacco causes over 17,000 deaths each year in the country. The tobacco industry also continues to fuel this crisis by promoting its products, lobbying against tobacco control policies, and misleading the public about health risks, and also targeting vulnerable groups. In response, Ethiopia signed the WHO Framework Convention on Tobacco Control in 2004 and ratified it in 2014, and also enacted Proclamation number 1112, 2019. It's Ethiopia's comprehensive tobacco control law. This law enforces 100% smoke-free public places. It also no designated smoking area allowed, bans tobacco advertising and single cigarettes. It's a comprehensive law, so I will not go into detail. Next slide. Next slide, please. Okay, thank you. This slide gives an overview of the Global Tobacco Surveillance System, or GTSS, which provides standardized data to help countries monitor tobacco use and guide evidence-based tobacco control efforts worldwide. GTSS has three main components: the Global Youth Tobacco Survey, GYT, the Global Adult Tobacco Survey, GATS, and the Tobacco Questions for Surveys, TQS. Today, we are focusing on GATS, which is part of the GTSS. GATS provides a global standard to monitor adult tobacco use and key tobacco control indicators. It is a nationally representative household survey of individuals aged 15 and older. It follows a standard questionnaire, sample design, and data collection procedure to ensure consistency across countries. Next slide. Now I will explain the methodology used for the second round of GATS Ethiopia without going into the details of the data collection process. Starting with the sample size determination. Following the GATS sample design manual, we calculated the sample size using key statistical variables such as design effect, margin of error, and prevalence estimates of selected indicators from GATS 2016. The initial target was 13,333 completed interviews. After adjusting for non-response and ineligibility at both individual and household levels, the sample size increased to 16,211 households. For the sample design, we applied a multi-stage geographically clustered approach. In the first stage, Ethiopian Statistical Service Institution selected 559 primary, sorry. Yeah. In the first stage, Ethiopian Statistical Service selected 559 primary sampling units from the master frame of over 100,000 primary sampling units across the country using probability proportion to size method. In the second stage, 29 households were systematically selected within each PSU by field staffs. In the final stage, one eligible respondent aged 15 or older was randomly selected from each household using a tablet-based selection tool. Next, please. Okay, the GATS findings are usually presented within the Empower framework, covering tobacco use prevalence, second-hand smoke cessation, media, health warning, all the 6 components. However, in this presentation, I will focus only on second-hand smoke exposure. The GATS 2024 results show both progress and remaining challenges when compared to 2016. Significant reductions in exposure were observed in several public venues or settings, such as workplace, universities, restaurants, and bars and nightclubs. Workplace exposure decreased from 32.2% to 19.8%. Universities from 32.8% to 18.6%. Restaurants from 33.3% to 20.2%, and bars and nightclubs from 71.8% to 57.3%. Despite these improvements, exposure remains highest in bars and nightclubs. In homes, public transportation, and schools, exposure also declined, but not significantly. At home, from 15.2% to 14.0%. In public transportation, from 12.2% to 11.2%. And in schools, from 13.5% to 10.5%. On the other hand, a slight increase in exposure was observed in healthcare facilities, from 8.4% to 10.7%, and government offices also as well, from 22.1% to 23%, indicating areas where enforcement needs to be strengthened. Overall, these reductions demonstrate the positive impact of Ethiopia's 100% smoke-free policy. However, to sustain progress, stronger enforcement, public awareness, and monitoring are needed. Next slide, please. This slide shows changes in awareness of second-hand smoke health risks between GATS 2016 and 2024. In 2016, 75.9% of adults believed second-hand smoke causes serious illness, including 66.1% of smokers and 76.3% of non-smokers. By 2024, overall awareness increased to 80.9%, with 81.7% among non-smokers. However, awareness among current smokers declined slightly to 62.1%, while overall progress is encouraging. The decline among smokers highlights the need for targeted reduction to improve its perception. Next slide. To close the presentation, I will highlight key recommendation from GATS 2024. First, stronger enforcement of Proclamation Number 1112/2019 is needed, especially in high-risk settings like bars, nightclubs, government offices, and healthcare facilities, with regular inspection and penalties for violation. Second, public awareness should be expanded through media and community outreach, promoting smoke-free norms and specifically targeting smokers who often undermine second-hand smoke risk. Third, continuous monitoring through surveys and observational studies is essential to track progress. Finally, stronger multi-sectoral collaboration across government, civil society, and hospitality sector is critical. Next slide. Yeah, before concluding, I would like to acknowledge all institutions, organizations, and individuals who contributed to the successful implementation of GATS Ethiopia 2024, as displayed in the slide. Okay, thank you. Okay, thank you all for your attention.
Thank you, Kirubel. I would like to open it for questions. If you've got any questions, please pop them in the chat. And while I wait for those, I would like just to pose two to Kirubel. And so the first question is, we've noted that the places with the most exposure are still bars and nightclubs. What would you say needs to be done to improve enforcement of smoke-free in bars and nightclubs? And perhaps what's the enforcement challenge with the bars and nightclubs? So you made a recommendation, stronger enforcement, but what exactly needs to be done? And then two, we noted also that the smokers have got less awareness of secondhand smoke risks than non-smokers. And again, you called for increased awareness. how could this increased awareness be done so that the smokers actually get the message? And maybe the question is, how then maybe do we use the cigarette packet in terms of the warning labels? So how can we get to smokers? And then the last one would be, what other research on smoke-free is needed in Ethiopia? Kirubel, you're on mute.
Okay. Okay, let me begin from the first question. In bars and nightclubs, the exposure is still very high. It's almost above half of the respondents exposed to second-hand smoke exposure. It's a big number. This is due to weak enforcement of proclamation number 1112 2019 in different settings. We have strong smoke-free law, but there is a weak enforcement and also limited inspection. I think there is also low awareness among owners of the business and also the customers. And occasionally there is also tolerance of indoor smoking. The people tolerate when the people smoke near to them. So we need to strengthen the enforcement, and there should be also periodic inspection of these settings. What's the second question?
So the second question, Kirubel,
Yes.
was the awareness on the risks needed. Kirubel?
Okay, I think tobacco control is not a single organization or individual task. It's a multi-sectoral responsibility. So in Ethiopia, we have conducted several researches, including GATS and GYTs, also other observational researches. So we could identify the areas that need improvements. So we need to collaborate. We also have a tobacco control coordination committee in Ethiopia. It brings together different stakeholders. So through this committee, we can identify the areas and we can work collaboratively.
Okay. One last one from the chat before we move to the next speaker. Smoking is increasing in health facilities and government buildings in terms of increased secondhand smoke exposure. Why is this and what can be done?
Yeah, it's a great question. Yeah, in healthcare facility and government buildings, the exposure has increased from the first round of GATS. This might be the reason the EFD, Ethiopian Food and Drug Authority, may focus on other settings. So this finding highlights that we need to focus on the government institutions if they are complying with smoke-free compliances. So it needs inspection, regular inspection in these settings. So there should be zero exposure, especially in healthcare facilities. So we need to give attention in these settings.
Thank you very much. Would like to move to our next speaker. Our next speaker is Professor Wagari Deresa. He's a professor of epidemiology and public health at Addis Ababa University, and he'll be speaking to us about compliance with smoke-free laws in hospitality venues in Ethiopia an observational study in 10 cities. Welcome, Professor.
Yeah, thank you very much. My name is Wakari, as you mentioned, from Addis Ababa University School of Public Health. I'm going to present the overview of our key findings related to tobacco compliance with regard to smoke-free laws in Ethiopia at hospitality venues. And I will say some points related to the rationale and also the objectives, the methods, key findings, conclusions, and recommendations. Next. So, as has been by the earlier presenter, the 2019 proclamation of Ethiopia is highly comprehensive, and it included 100% smoke-free at public and workplaces, where hotels, restaurants, bars, and cafe, grocery, nightclubs, and lounges are also included as a workplace. And these places specifically, they have high exposure to the second-hand smoke, and especially attracts the younger population, adult customers, both smokers and non-smokers. And particularly when customers who are non-smokers are also experiencing higher levels of second-hand smoke. And again, workers in this hospitality venues are also repeatedly exposed to second-hand smoke. With this rationale in background, the study objective was to determine the level of compliance with smoke-free laws at hospitality venues in 10 cities in Ethiopia. Next. Next slide. Rachel, yeah,
Slide has moved. Go ahead. Hello, Prof.
Yeah, it has been disconnected, I guess. So, sorry, with regard to the methods, we included, as I said earlier, 10 cities in Ethiopia, including Addis Ababa, Adama, Bahar Dar, located in different parts of the country, where more than 7 million population are residing in these areas. And we used a cross-sectional study with multi-stage cluster sampling. And this was conducted in December 2022 using standardized data collection tools, including covered observation, data collection time during the evening up to the midnight. And for data study, we secured IRB approval from the Ethiopian Public Health Association. Next. So the key findings include these key findings are related to the indoor compliance. We have also conducted some observations outdoor, but this finding is mainly related to the indoor compliance. And just from the so if you include, for example, no outdoor smoking within 10 meters, no cigarette butts, no smoking signage, no indoor tobacco use, and also no tobacco product for sale, no lighter, no ashtray, and no designated smoking areas, up to the no shisha equipment. So if you see from the mid to the bottom, from no tobacco product for sale, no lighter, more than 80% complied, but especially the cigarette butts and no smoking signage and no outdoor smoking within 10 meters from the outdoor is from the entry is very low with regard to this one. And outdoor smoking within 10 meters of the entrance is very, very common in this study, more than half. Next. So the next is the question included whether anyone used tobacco product in hospitality venues by venue type, where about 32% of the hospitality venues included demonstrated this one. So with nightclub lounges having the highest, and we have in this also the outdoor, which is red bar within 10 meters, and the indoor, which is a blue bar. So night clubs, lounges, and bar and grocery, they have the highest, and cafes and the restaurants at the bottom, they have the lowest. In all the categories, the outdoor smoking was higher than indoor smoking. Then by city, the highest one was demonstrated in the eastern part of Ethiopia, in Samara, Afar region, Logia, and followed by Dredawa, and also Gambela, Harar, Asosa, and the list with Bahir Dar, Adama, and Jijiga. And still in this slide, the outdoor within 10 meters smoking was higher than the indoor. Next. Next.
Hi, Prof. The slide has moved.
And the next is the no smoking signage posted in hospitality venues, including the outdoor in the different parts of the hospitality venues inside. And this was demonstrated in 35% of the hospitality venues, where the highest was
Hi, Prof.
yeah, where the highest was happened in the hotel, followed by cafe and restaurant, bar and restaurant. But with regard to grocery and also nightclubs, including restaurants, this was the least observed. Next. The other is by city. We're still in Samara Logia, in Afar region, Harar, and Addis Ababa. No smoking signage posted was the highest, but the list in the Jijiga, in Bahir Dar, in the Gambela. But you can see that the last bar about Samara Logia, this was very high. But also in terms of someone used tobacco, this was also very high in Samara Logia. It is the hot spot for smoking, and during our time, 2 months or 3 months earlier, there was a campaign against tobacco smoking in the area, and this no signage was done in the hospitality venues as a campaign during those times. That's why this percentage of no smoking signage is very high there. Next. Then this study also included with regard to PM 2.5 concentration, particularly it was done in Addis Ababa. And if we see, for example, one of the study hospitality venues, this was taken as a grocery in Addis Ababa, and the WHO recommendation is the broken dot line at the bottom, which says 15 microgram per meter cube. But in that particular grocery in our study, it was very, very high, up to the level of 800 to 1,700, and this was published also as the first one was also published. So the WHO recommendation for 24-hour is a short-term exposure, which is 50 microgram per meter cube, but our finding was very, very alarming, and this is at the hazardous level, which is very, very dangerous for the health of the people, especially in those hospitality venues like nightclubs and lounges. Next. So with conclusion, indoor compliance is higher in our study when compared to outdoor compliance within 10 meters. And we observed very low compliance at bars, nightclubs, and lounges, and also in cities like Semara, Logia, and also Gambela. And hospitality venues compliant with smoke-free laws, as we have seen, varied significantly with the cities and geographic locations, as well as also the different types of the hospitality venues. So this will lead us to the recommendations, which is very similar to the former, the previous speaker, Ruben. So this study is targeting interventions are essential, particularly in high-risk areas like bars, nightclubs, and lounges, and also in those cities, particularly in the eastern and in the southwestern Gambela. So the one recommendation is that the regions and the cities should have their own implementation guidelines and budget, because this is region-based, and also continuous education of the public about the health effects of tobacco and also its harmful effects is very, very essential. And this is one of our recommendations. Thank you very much.
Okay, thank you, Prof. Wagari, for your presentation. I will go to the questions in the chat. So the first is from Mohammed Sidi. What was the sample size in your study? And the second question I have for you is, how can the study findings be used to improve enforcement? And so, for example, how are you disseminating these findings? And then the last one is a comment in the chat from Noreen, where she says that the results from the two studies seem to be very consistent in terms of overall exposure in bars and nightclubs, although they used different methods, observation versus self-reported exposure, which increases the confidence in the findings and points to a need to have interventions targeted at these establishments. So to recap the questions, what was the sample size? 2, how can we use these findings to improve enforcement, particularly in the geographical regions and the facilities where exposure was high? Go ahead, Prof.
Yeah, thank you very much. With regard to the sample size, we had the standard calculation at that time, and it was for hospitality venues, it was 1,360, and in each city, our sample size was more than 100, to the extent of like 250 in Addis Ababa. So relatively, the sample size was very high compared to the smoke-free law study or research guidance, and that's really interesting. And I think those of you who are interested in both studies, the PM 2.5 and the smoke-free laws in 10 cities, these studies are already published, and further information or further, I think, evidences can be found within those published. And I think it will be shared on the chat, the link. The next one is the study findings are really very, very important for us, for Ethiopian government, especially Ethiopian Food and Drug Administration Authority, and also regional health bureaus like tobacco regulatory offices, and it goes to the Warada level. And we have made we made disseminations at national, at international level also. And publication is also one of those things. And I think the findings can be really helpful for those who are really involved in enforcement. What are the challenges and where the target areas are there, the target hospitality venues, the target locations where the compliance is very low. Those things are really guiding us for those things. And the comment by Noreen is, I am also fascinated about the agreement between the GATS findings and our study. And this is also one of the validations that we can use, and it complement each other. So I think that's a very good finding, and thank you very much, Noreen, for pointing out this point.
Okay, thank you, Prof. A reminder to people, we can put questions in the question and answer function. We can also put them in the chat function. I'm seeing another question from Adeleke. Why were the data not subjected to statistical analysis? The results will be more impactful and in tandem with other biological or pharmacological data. Plots could be made to significantly compare all outdoor and another for all indoor. Prof. Wagari and Tesfaye, could you please respond on statistical analysis?
Yes. For us, the presentation that I made is descriptive one, but they are very, very informative. We have also made this statistical analysis, advanced analysis in our articles, and we have received also a lot of comments from the reviewers of the articles, which were really very helpful. And during the dissemination also, we received a lot of things. And we have also identified areas where to focus for the next research, especially in terms of hospitality venues in Ethiopia.
Thank you. Kirubel, do you want to say anything about statistical analysis before we move to the next speaker? Okay, let's move to the next speaker. Our next speaker is Mr. Emmanuel Abraham. He works as an Assistant Chief Scientific Officer at the Federal Ministry of Health in Nigeria. Welcome, Emmanuel, and he'll be talking to us about secondhand smoke exposure in hospitality venues in Abuja, Nigeria. Welcome, Emmanuel.
Thank you so much, Rachel. And it's my pleasure to share with us findings from our research on exposure and likely effect of secondhand smoke among hospitality workers in Abuja, Nigeria. Next slide, please. This would be my outline. Next slide. Okay. As we know, secondhand tobacco smoke is a well-documented preventable cause of diseases and premature death. And scientific evidence has shown that there is no safe level of exposure to secondhand tobacco smoke. Even brief exposure can cause serious harm. So why did we address hospitality workers? It's because these people work long shifts, mostly in enclosed environment, where exposure is frequent, prolonged, and largely involuntary, resulting in elevated exposure levels and associated respiratory symptoms among these workers, especially in venues where indoor smoking is still permitted. Next slide. So in Nigeria, Nigeria passed the National Tobacco Control Act in 2015, Our act provides for designated smoking areas. However, WHO recommendation is for countries to go 100% smoke-free. Nigeria currently provides for designated smoking area in venues such as hospitality venues. Also, local literature on secondhand exposure among hospitality workers remains limited, especially for Abuja. Most previous studies had focused on state-based legislations, and these studies were mostly carried out before the passage of the National Tobacco Control Act. So to bridge this gap, our study provides a baseline assessment of exposure and self-reported health symptoms among hospitality workers in Abuja post-implementation of the National Tobacco Control Act. Next slide. With regards to methodology, we conducted a cross-sectional descriptive study using a multi-stage sampling techniques. Eligible participants were those who were 18 years and older, those who had worked in the venue for at least 6 months, and those who had direct contact with customers, as well as those who would communicate fluently in English language. Data was collected from 300 respondents across 160 hospitality venues in Abuja, Nigeria, from October 2022 to February 2023, and we had a response rate of about 70%. We used bivariate and logistic regression analysis to analyze the data, and significance was set as p-value greater or equal to 0.05. Less than, sorry, 0 or equal to 0.05. Next slide. Our results showed us that participants, we had 207 of our participants were males, and 31 of them were females. And the study also showed that 34% of respondents reported exposure to secondhand smoke at work. That's, given that value, that's 1 in about 3 hospitality workers were exposed to secondhand smoke at work. The result also showed that there was a significant relationship between educational status, secondhand smoke exposure, secondhand smoke indoor policy, designated smoking area availability, ability to control exposure to secondhand smoke, and frequency of exposure to secondhand smoke. For example, educational status, we observed that those who had higher educational qualifications were less exposed. Of course, the reason for that is not far-fetched, because those who were more educated had higher responsibilities, higher offices, occupied higher offices, and their contact with clients were not as pronounced as those who were less educated. And also ability to control exposure. Some respondents noted that they could control exposure. For example, they could politely ask the client to stop smoking. Some said they could walk away. Some said they could report to management. And so those who had ability to control exposure were less had less frequency of exposure to secondhand smoke. Next slide. Next slide, please. Okay, so we carried out logistic regression model. However, before that, we did chi-square analysis to look at socio-demographic and organizational factors associated with frequency of exposure. And our study had showed us, I talked about the association we found. However, the logistic regression model showed that participants who were required to self-client in designated smoking areas were more than 8 times more likely to be exposed to secondhand smoke compared to those who don't have where there was no designated smoking areas. So workers required to serve in designated smoking areas were over 8 times more likely to report being exposed to secondhand smoke. I'd also talked about participants with secondary education. They were significantly less exposed to secondhand smoke than those with only secondary education. Next slide. For the reported respiratory symptoms, the results showed that 16.3% of respondents reported at least one respiratory symptom, such as wheezing, dry cough, runny nose, and shortness of breath. Next slide. Yeah, so logistic regression model revealed that there were two strong predictors for respiratory symptoms. One was frequency of secondhand smoke exposure, and the result showed that workers exposed to greater than 15 days in the past 30 days were over 6 times more likely to report respiratory symptoms. The next was control over secondhand smoke. Workers who could control their exposure were significantly less likely to report respiratory symptoms. Next slide. So we wanted to find out about the perception on exposure to secondhand smoke. Interestingly, many workers expressed concern about their health and showed support for full indoor smoking bans. Most workers, they had already, they indicated in the study that they will support smoking bans, and most of them were aware of the health concerns with regards to exposure to secondhand smoke. Next slide. So in conclusion, this study indicates that about 1 in 3 hospitality workers in hospitality venue in Abuja are exposed to secondhand smoke, which is largely due to partial smoking restriction and presence of designated smoking areas. Workers also reported respiratory symptoms such as wheezing, dry cough, runny nose, and difficulty in breathing, which may be attributed to their exposure to secondhand smoke. While a causal link cannot be fully established because of the nature of this study, it's important to protect workers in this venue from exposure to secondhand smoke and its associated health effect. Therefore, we're recommending that implementing comprehensive smoke-free laws in public places, mass sensitization campaigns, and effective enforcement are needed to safeguard the health of hospitality workers to fully comply with the WHO FCTC as well as the National Tobacco Control Act. These are my references. Thank you very much for your time.
Thank you, Emmanuel. A couple of questions I have for you. So starting from the chat, Noreen is asking, why do you have a lower age limit for the study when those that are younger might be more vulnerable to the negative effects of secondhand smoke exposure? Would this not lead to underestimation of the effects? Was this driven by ethics requirements? Emmanuel?
Okay. Thank you so much, Noreen, for this very important question. We used 18 years because we wanted to get the consent of all participants. And, officially, you're more likely to get a job when you're 18 years and above, and the official age is 18 years. So that's why we used workers who were 18 years and above. We wanted to get their consent, and based on the fact that this is the official working age, we stuck by that for 18 years. Thank you.
Okay. 2 more questions from me, Emmanuel. So one is first a comment. I found it interesting. I find secondhand smoke is often seen as a women issue, that we normally say it's the men that smoke and the women that are getting exposed. But from your study participants, more were men, meaning that at least in the workplace, secondhand smoke also seems to affect men. And so in terms of how we do our messaging around secondhand smoke, what could you say you have learned that influences how you need to message on the issue? And then secondly, how can we empower workers to enforce smoke-free? Because you also mentioned if they were higher educated, then maybe they had more bargaining power in the workplace. So what can we do to empower them to get their workplaces smoke-free? And then the last one would be, how can we use these study findings to get tighter regulation of smoke-free or better enforcement?
Thank you so much. Thank you so much, Rachel. I think in tobacco control, interventions are always targeted. When you're targeting hospitality workers, it's different from targeting people in other venues. With regards exposure to secondhand smoke at home, women and children are more exposed because you have more men using the product. However, for this study, we're looking at workers. It just happened because I didn't have time to talk a lot about the sampling methodology, but I said we use multi-stage. So we sampled, we did random sampling for the hospitality venues, but at that hospitality venue, we did convenience sampling. Once you met all the selection criteria, you were selected. And we also noted that we had more men working in this hospitality venue. So of course you have more of them in the study. So that's why we had more men in this study and also in exposure. In order to empower these workers, a lot of them, for this study has shown us that they are aware of the health effect associated with exposure. However, they are scared about job loss. That's one thing we also noted. They're scared about job loss. So they won't just cry out to management because they also want to ensure that they are in job, that they don't lose their job, especially when the unemployment rate is very high. And they also these are study corroborated other studies that have shown the same thing, that the scale of job loss, but that needs to be addressed properly because most studies have shown that with effective implementation of smoke-free public places, there won't be, the hospitality venues will not have reduced clients. Instead, they'll have increased clients because there are several clients that will want to use this venue, but because people smoke in these venues, they will not be free to use the venues. So empowering workers is very important. And one thing we've done, I've shared this finding with Hotel Owners Forum as Abuja, which is the body coordinating hospitality venues, because they got the approval to carry out this study. They gave me their hotel list, which we did random sampling from. I've shared these findings with them, and we also intend to publish these findings very soon. Manuscript is being reviewed, and we intend to publish it and disseminate it to a wider audience very soon. Thank you.
Okay, last round of questions from the chat. Did you see any outlet that has a DSA while you are doing your research? 2, as a government officer, do you think government has done enough to stop this ugly trend? And 3, what specific policy and program recommendations are you making?
Okay, thank you so much. Very important questions. Firstly, did I see DSA in this study? This study was not an enforcement study. So what we did was to interview respondents. So where in areas where there was no DSA and they said there was DSA, we didn't argue with them and we documented what we had. But over time, I think our experience has shown us that a lot of these facilities, they call some of the rooms designated smoking area and some non-designated smoking area. From experience, we've also seen that some have designated smoking area, but the issue is with regards the level of compliance with the law in constructing the designated smoking area. So personally, we did not investigate if they had designated smoking area. However, this study is in line with several studies which showed association between exposure and designated smoking areas. So this study is not an outlier from several other studies going to show that are evident the data we collected is factual. The second question is regards the government or as a government officer. I think I would want to downplay this question because I'm here in my private capacity, not as I'm not speaking for government, but I think a lot is being done to sensitize hospitality workers. I know a lot has been done. Several interventions that have been carried out is promoted. So I think I've been able to answer those questions. If there's anyone, please kindly let me know. But I think I've been able to answer the questions that have been asked. Thank you.
Okay, thank you, Emmanuel. As we move to winding up, I would just like to remind us that in the chat, the research publications from Ethiopia have been posted, both in the Q&A and in the chat. I would also like very quickly to just share the dashboard page where the Ethiopia results can be found. The TCDI Ethiopia dashboard page. And on this enforcement page, you've got all the study findings that Professor Wagari was sharing. But in addition, the dashboard has other topics. So as you go through the dashboard page, on your left, you have got a navigation bar. And so you can click on it, and it will take you to the different components of the page. And the page uses information largely from Ethiopia as bolstered with other information, and then different forms of infographics, all of which can be downloaded in case you need to use them. And then lastly, a reference section at the bottom that shows you where all of this information has come from. And so it works as a kind of one-stop shop for all the information you need. And as I mentioned, there are 5 other dashboards. So in addition to Ethiopia, we have a dashboard. If Salam, you could go up to the top. So on Ethiopia page, we have got 6 pages. The Ethiopia dashboard is currently being translated into Amharic. So in a few weeks' time, we will be letting you know about the Amharic version. So watch this space. And then we also have other countries that have dashboards, and they can also be accessed. Salam, if you can show them where they can get the other dashboards. Yes, that is where all the country dashboards can be found. So we encourage you to go to the dashboard and see what is there. Lastly, as we wind up, this is our second webinar series. We still have a few more coming. And so we'll be hearing about illicit trade studies that TCDI has carried out, morbidity and mortality studies that TCDI has carried out, and also a webinar on adolescent tobacco control data that TCDI, that Development Gateway has carried out in 3 countries. So please keep track of our emails, our WhatsApp messages. We'll be letting you know about these further upcoming webinars. You're always welcome to reach out to us in case you have got any questions or any topic that you would like covered. And I thank you all for attending today. Thank you to our panelists, Professor Wagari, Emmanuel, and the guy from Ethiopia Public Health Institute. I wish you a good afternoon and rest of your day. Thank you very much.
Thank you very much. Good. Bye.
Thank you.
Thank you. Bye.